We are going to discuss on a very interesting topic on respiratory failure. Respiratory failure topic understanding needs a lot of core concepts to be understood first of all. At the same time, a lot of things you apply here, you also apply it in ABG, acid-base balance. Even though these two topics are discussed separately, one in nephrology there and one in respiratory medicine here, both are going to go hand in hand. So stay with me. So the medicine is not like what you think, it's not something discrete topics, it's all about a compendium of a single topic called medicine. So that's why I see medicine, but that's why I wanted everyone to see medicine. So that's why the entire app is all about. Anyways, so let us go into the respiratory failure and let us see some of the basic formulas and basic values that you need to know for respiratory failure. The first one is the PaO2, that is nothing but partial pressure of arterial oxygen, which is approximately in the range of 75 to 100 millimeters of mercury. And you have something called partial pressure of arterial carbon dioxide, which is approximately in the range of 36 to 44 millimeters of mercury, and you have pH, which is in the range of 7.36 to 7.44 approximately. So these are some of the important values that you have to know for respiratory failure. And we also have discussed one of the other important values, something called an AA gradient. So people who have not watched what is AA gradient, let me tell you what is AA gradient is. As I told you, you have an alveoli. So in the alveoli, you have this air alveoli barrier or blood air barrier is there. So what do you mean by this blood air barrier? It is composed of the alveolar basement membrane, alveolar capillaries, and the alveoli itself. So let us put this pink to be the base membrane, the red one to be the capillaries, and the black wall to be the alveolar wall itself. So what is going to happen is, as I told you, your partial pressure of atmospheric oxygen is approximately in the range of 150 millimeters of mercury or approximately 160 millimeters of mercury. So which comes in and forms partial pressure of alveolar oxygen. As I told you, the partial pressure of alveolar oxygen is not going to be the same as that of partial pressure of atmospheric oxygen. I told you that the main reason being the culprits, a lot of contamination is going to happen in the form of water vapor that is present in the conducting zone. At the same time, we have a lot of CO2 that is coming as a result of gas exchange into the alveoli. So the PaO2, that alveolar oxygen that is going to come, that's going to be present in the alveoli, is approximately only 100 to 110 millimeters of mercury as an average. But even though I tell this is a normal physiological P alveolar oxygen or partial pressure of alveolar oxygen, you have something called an alveolar gas equation. You are going to have an alveolar gas equation that is going to determine what is the amount of your partial pressure of alveolar oxygen. As I told you, the alveolar gas equation is going to tell something called your partial pressure of inspired oxygen minus your partial pressure of arterial carbon dioxide divided by your respiratory quotient. We already saw what you mean by this partial pressure of inspired oxygen. This you can give by the formula, that is P atmosphere, the partial pressure of atmospheric pressure minus water vapor pressure multiplied by fraction of inspired oxygen. So at sea level, the atmospheric pressure is going to be 760 and partial pressure of water vapor is going to be 47 multiplied by FiO2, which is variable according to which is the mask device that you are going to use for the patient. So the PaO2 calculation is going to be like 713 into FiO2. This you can set as a standard as long as you are at the sea level. But if you go to the high altitude, the 760 varies, which means this cannot be fixed and this also is going to change. So the final alveolar gas equation, you can give it as 713 multiplied by FiO2 minus your partial pressure of arterial carbon dioxide divided by 0.8. You know that this 0.8 is the respiratory quotient in a patient who is going to take a mixed diet. Am I right? So because the patient is going to consume both carbohydrates and fats, average of both can be taken as 0.8 because the respiratory quotient of carbohydrates are going to be 1 and the respiratory quotient of fat is going to be 0.6, and the average you can take it as somewhere around 0.8. So this is the standardized formula that we typically use in our ICUs for determining the partial pressure of alveolar carbon dioxide. But what you mean by this AA gradient? For measuring the AA gradient, you need two values, that is partial pressure of alveolar carbon dioxide and partial pressure of arterial carbon dioxide. So typically we have this partial pressure of arterial carbon dioxide which you have measured through the alveolar gas equation. And you also have this partial pressure of arterial carbon dioxide. Typically you are going to do that by ABG, acid base sampling, your ABG analysis, arterial blood gas analysis. Clear? So what do you mean by this A gradient? So I told you this is going to be the PaO2 and here is going to be the P capital AO2 and some amount of oxygen, I mean not some amount of oxygen, in fact almost all the oxygen is going to diffuse into capillaries to produce the partial pressure of arterial oxygen. Probably you can think as some is going to get spilled out and some spillage you can expect that it can move out from the in between the interstitium, so that there will be some difference between the partial pressure of alveolar oxygen and partial pressure of arterial oxygen. Normally the PaO2 minus PaO2 small a02, that is the AaO2 gradient, must be less than 12 millimeters of mercury, and this is something very important number. So the same number we are going to use for the anion gap as well. That's why this is a very, very important number. Or you can give a normal A gradient. Some books will give you other options for normal A gradient is age divided by 4 plus 4, or you can put it as age multiplied by 0.3. You can take the upper limit of normal of A gradient. At the same time, you can tell less than 30 also, you can take it as A gradient according to certain standard textbooks. So it all varies, but in my general practice, we as a critical care physicians, we tend to take this A gradient as less than 12 as a standard. So what is this 12? What this number depicts in general? This number depicts, you can remember this number as two important things. See, remember some difference between this PaO2 and PaO2 is important to make the gas diffusing. You know, like always your PaO2 should be high and arterial oxygen should be low. The alveolar oxygen should be high and arterial oxygen should be low, because you have to push oxygen from a region of higher concentration to a region of lower concentration by a process called diffusion. So you need that gradient to happen. First of all, you need that gradient. That whatever the gradient may be, maybe 2, maybe 3, doesn't matter. You need that gradient for continuous movement of oxygen across the barrier into the capillaries. If it's the other way around, your oxygen is going to move from the capillaries into the alveoli, and that is not going to happen anywhere in your life. Clear? So okay, fine. In first way, the physiological principle, the gradient must be there and existing to push the oxygen into the capillaries. Point number 1. And number 2, how much you need the gradient? You need a small amount of gradient is enough to push the like oxygen from the alveolar side into the capillaries. You don't need a gradient of 100 or 200. If you have a gradient of 100 or 200, it means something is wrong, which means your movement of the oxygen is poor, which means your alveolar oxygen is so high and your arterial oxygen is so low. That is the reason why your gradient is so high, which means there is some problem in the movement of oxygen and the diffusion barrier. So that's what it means. Clear? And that should not happen, right? So that's why whenever the patient is going to suffer from hypoxemia, the next step is to look for the A gradient. This is the very, very basic of a respiratory failure. You're going to see the A gradient first. If the A gradient is increased, which means I'm going to tell there is some problem in the diffusion barrier. There is something wrong that is happening. I don't know what, but something wrong in the alveoli or in the capillaries or in the base membrane or in the interstitium. Something is preventing this movement of alveolar oxygen into the capillary blood. So whenever it's increased, this is what we refer to as something called a classic type 1 respiratory failure. Whenever the A gradient is normal, but still you have an hypoxemia, it means, you know, hypoxemia means it is low partial pressure of arterial oxygen. Typically anything less than 75 is hypoxemia, but critical hypoxemia means less than 60, which will come to that later on. So you have an hypoxemia, but a normal A gradient. What does that mean? So you have an alveoli, you have a capillary, and you have a basement membrane. Let us draw the capillaries a little bit thicker. So this is the blood-air barrier. Clear? And what do you mean by a normal A gradient? And you have an hypoxemia as well. Hypoxemia means you have a low partial pressure of arterial oxygen, but you have a normal A gradient. That's what I mean, which means I told you whenever you have a normal A gradient means the diffusion is all right, the diffusion is okay. The barrier is fine, there is no problem in the barrier, there is no problem in the exchange of oxygen. Then where is the problem? So let us work it out. So PaO2 minus P small aO2 is equal to, I'm telling it's normal, maybe let us say it's 10, it's normal. So here I told you, let us keep an arbitrary example for an hypoxemia. Here I'm telling that your partial pressure of arterial oxygen is just maybe 50, let us assume. So I'm giving an example. So PaO2 minus 50 is equal to 10. So which means the partial pressure of alveolar oxygen is 10 plus 50 is equal to 60, which means what we saw, the normal partial pressure of alveolar oxygen is somewhere around 100. But in this example, we are seeing a 60, but the A gradient is absolutely normal, it's 10. So what does that mean really? It means that here you have only 60, here you have only 50, which means the diffusion is absolutely alright, the exchange of oxygen is absolutely alright, but the amount of oxygen that is entering into the alveoli itself is less. That's why your alveolar oxygen itself is only 60. That is the idea here. Clear? So tell me some some smart causes that can reduce the partial pressure of alveolar oxygen. Not the, because of the reduction, the primary problem here is the reduction in the alveolar oxygen. That is the reason why your movement is fine, but since the incoming oxygen itself is less, the outgoing is also less. That is the reason why the capillaries are showing less oxygen as well. So what are the conditions that can cause the low partial pressure of arterial oxygen? Very simple. If the environmental oxygen itself is very less, suppose what the oxygen you are breathing itself is very less, obviously what is going to come in is going to be very less. So typically this happens in a high altitude. High altitude is a characteristic example of hypoxemia with a normal A gradient. Clear? But in reality, when you go to an ICU setting, if you can't tell the patient is living at a high altitude, that becomes a very nonsensical cause. So you have to tell that the patient is breathing a low FiO2, which means probably anything, probably a ventilator circuit would have failed, or oxygen may not be delivering to the patient properly, and this is one of the very common reasons why you get this problem in the ICU. With a normal A gradient, at the same time you have hypoxemia. So beware of this. Low FiO2 states. Patient is inspiring a low oxygen. Clear? Due to some equipment malfunction or circuit failure. Second thing, if the patient is not breathing at all. Second is if the patient is not at all breathing. So what do you mean by not breathing? I'm not willing to breathe, or I'm not breathing because my muscles are not working properly. So if I'm not able to breathe, or if I'm not breathing properly, so that is what we refer to as something called an alveolar hypoventilation. Alveolar hypoventilation. Clear? So which means I'm not breathing insufficient oxygen at all in the first place because my breathing is improper. At the same time, if I'm not breathing properly, I told you one gas that gets affected dramatically when you don't breathe is carbon dioxide rather than oxygen. So the carbon dioxide that is going to diffuse, the only way for this carbon dioxide to move out is by breathing it out. So here you are not breathing properly. So what's going to happen is this carbon dioxide is going to accumulate within the alveoli. The moment the carbon dioxide is going to accumulate within the alveoli, it is going to stay back, and the further movement of carbon dioxide into the alveoli, because the gradient will be lost, because of that the CO2 starts accumulating in the body and the capillaries, also resulting in increased PaCO2, and that contributes to the type 2 respiratory failure. Clear? Which we'll discuss later on in detail. Understood? Yeah. So because there are a lot of people over here, a lot of carbon dioxide over here, at the same time this carbon dioxide will restrict the movement of oxygen into the alveoli. At the same time, you are not breathing at all, that itself will restrict the movement of oxygen into the alveoli. So your PaO2 is going to drop. Because of that, your P arterial oxygen is also going to drop, but the A gradient will be absolutely normal because there is no problem in the gas exchange. Clear? Absolutely all right. Fine. So these are the classic causes: high altitude or breathing out low FiO2 states, or alveolar hyperventilation. These are the two classic causes where you can have A gradient with a normal, you can have a hypoxemia with a normal A gradient. So this is really important to understand. It's a very basic, even though I explained this already in my previous lectures, but still this forms the basic crux of understanding a respiratory failure, your AA gradient. So because we are going to classify your respiratory failure itself in ICU based on AA gradient only. So fine. So we have seen a decent amount of what do you mean by all this. So now, what do you mean by an hypoxemia and what do you mean by an hypoxia? So hypoxemia is something different and hypoxia is something different. Hypoxia is something different. So what do you mean by a hypoxemia? If your partial pressure of arterial oxygen is low, typically anything less than 75 millimeters of mercury, we are going to call as hypoxemia. But hypoxia is something different. Anything that causes impaired tissue oxygenation, we are going to call as hypoxia. Anything that causes impaired tissue oxygenation is we are going to call as hypoxia. Always do remember, hypoxemia almost always leads to hypoxia, 100% of the time. But hypoxia may not be due to hypoxemia. Clear? May not be always due to hypoxemia because hypoxia itself has a lot of causes. One of the types of hypoxia is hypoxemia. So it's not vice versa. Hypoxemia always leads to hypoxia, but not all hypoxias are due to hypoxemias. One classical example where you can see is when you have a stroke, your vessels are occluded where the blood oxygen that is mixed may be completely normal, but you get hypoxia to the brain because of the occlusion and reduced blood flow to the brain. So that there is no hypoxemia there. There is only hypoxia to the brain. So hypoxia can happen without hypoxemia. You have to know that, but hypoxemia all the time leads to hypoxia. So low PaO2 less than 75 millimeters of mercury is what we are going to call it as hypoxemia. But there is an entity called a critical hypoxemia. What do you mean by critical hypoxemia? If the partial pressure of arterial oxygen goes below 60 millimeters of mercury. So why so? Why you have this particular definition of less than 60, you call it as a critical hypoxemia. So it all depends on your understanding of the oxygen hemoglobin dissociation curve. Even though we have discussed a lot about this oxygen hemoglobin dissociation curve in the RBC section of hematology, still we have to know a little bit in respiratory failure. So first of all, you have to know that this curve is going to follow a sigmoid shape, which is very important to understand. It's not going to be like a exponential curve. It's going to be a sigmoid curve. Clear? So since it's a sigmoid curve, you can see that two things you can see. In the beginning, you can see the curve is very flat, and in the later part also you can see the curve is very flat. But in the center, the curve is going straight up. So this portion, green one, is what we refer to as the steep portion of the curve. And what we are going to plot against is the partial pressure of oxygen that is given to the hemoglobin versus the saturation of the oxygen in the hemoglobin. That is saturation content of oxygen, that is SO2. So typically, if you ask me why in the initial portion it is flat, it is because the hemoglobin is in the tense form. The moment you add more and more oxygen to the hemoglobin, they start entering the steep portion, which means they are going into the relaxed form, so they take oxygen more and more easily. And once again, they reach the maximal saturation point, which means hemoglobin molecule can carry up to 4 oxygen molecules only, but you cannot add more than that. So they reach the maximum saturation, that's why they go and become flat once again at the end. Clear? And if you ask me, how can you plot for arteries? If you take the partial pressure of arterial oxygen, which is supposed to be approximately 100 millimeters of mercury, just for understanding I am telling you, if you plot that in the arteries, since of very high oxygen content, the saturation is likely to be at its peak maximum. So which means the saturation of arterial oxygen is also going to be 100%. Clear? The hemoglobin saturation in the arteries is going to be 100%. Just for understanding, I'm telling you. But on the other hand, if we take a venous blood, so let us assume this is the partial pressure of venous oxygen. Let us put over here partial pressure of venous oxygen, which is typically somewhere around only 30 to 40 millimeters of mercury. So let us assume it's 40. It's around somewhere 30 to 40 millimeters of mercury. And if you see the saturation, so this is what we refer to as something called a mixed venous oxygen saturation, which is only around 65 to 75% normally. So why we call it as a mixed venous oxygen saturation? Let us see now. So there is also something called an oxygen extraction. So to understand the oxygen extraction, you need to know what is the content of oxygen that you're going to get. So the content of oxygen, we generally tend to call it as something called CaO2 for the arteries and CvO2 for the veins. So which means C stands for the content and O2 stands for the oxygen. A arteries and V for veins. So content of the arterial oxygen. Typically, how will you measure the content? So to measure the content of oxygen in any blood, you have to take hemoglobin and you have to multiply by the saturation of the hemoglobin in that particular blood and multiply by your 1.34, which should be added upon by partial pressure of arterial oxygen multiplied by 0.003. So this is what is going to give the content of the arterial oxygen. And you can see this value is going to be extremely negligible. This value is going to be absolutely negligible. And this is the only thing that's going to make real sense. I mean, in our real life scenarios. So this is the one that's going to give the content most of the times. Since in arteries, the saturation tends to be 100%, so you can tell in arteries under physiological conditions, it's going to be Hb multiplied by 1.34. But don't be bogged by that. Like usually, this is the usual correct formula. So multiply by saturation, because in ICU you often encounter low saturation. So this is the calculation you have to do. So if you take the content of oxygen in the arteries, if you do by all this calculation, it's approximately somewhere around 90 to 20 mLs per deciliter. So this is the natural content that you will get by plotting with the saturation. And the content of the venous blood, again, it's highly variable. The reason why it's highly variable is because different organs are going to extract different amounts of oxygen. It's not the same amount of oxygen that these organs are going to extract. So different amounts of organs are going to extract very, very different amounts of oxygen. So overall, the content of the venous blood will be 14 to 15 ml per deciliter. So that is 14 to 15 mLs percentage. So which means that there is a difference you're going to get over here between the arterial oxygen content and the venous oxygen content. So this difference is what we refer to as something called a oxygen extraction. That's called OTR, and it's very, very variable between organs. It's going to be highly variable between organs. And for example, if you ask the difference is maximum for a heart actually. So difference is maximum for a heart, which means heart is the one that's going to extract the maximum oxygen from a arterial blood. So the difference in heart is supposed to be around 11 to 12 mLs per deciliter. But here you see the difference is only approximately 5 to 6 mLs per deciliter. This is overall. Overall, it's only 5 to 6 ml per deciliter. But in the heart, it might be highly variable. It is 11 to 12 mLs per deciliter. So the one organ that extracts the maximum amount of oxygen from arterial blood is your heart. Again, a very important point. Again, you have a lot of other organs like kidneys, intestines, brain, which extract variable amount of oxygen from the arterial blood. Which means this CvO2, that's why I told you, is going to be highly variable depending on what organ system you are encountering. But remember, the CaO2 is going to be standard. For the same reason, your SaO2 is going to be standard, but whereas your venous oxygen saturation is going to be variable for different organs. So that is the reason we give a standard value called SvO2, that's called a mixed venous oxygen saturation. Why we call mixed? Because different venous blood contain different saturation and different oxygen content because of the different oxygen extraction by different organs, and they're going to mix and they're going to common place, and that is the reason why the best site for measuring this mixed venous oxygen saturation is the pulmonary artery, because that is the place where everything is mixed. So you get a common value. But if you take in the SVC, you might leave out the coronary veins and the IVC. You take the IVC and you might leave out the SVC, which is having different saturation because brain extract differently. So that is why the best site for assessing this mixed venous oxygen saturation is pulmonary artery through something called as Swan-Ganz catheter. This is otherwise referred to as a pulmonary artery catheter. Clear? So this is the best way to find out a mixed venous oxygen saturation. And you have a lot of stuff to know in this. You have something called SpO2, that's a mixed venous oxygen saturation, which you know already. You have something called ScVO2, this is superior vena cava oxygen saturation. And you have something called IVCO2, that is typically inferior vena cava oxygen saturation. So normally speaking, your SvO2 and ScVO2, your superior vena cava oxygen saturation, is going to be something very different, in the sense your SvO2 will be generally more than your ScVO2. This is a normal thing. Why your SpO2, this is a mixed venous oxygen saturation, is more than your ScVO2? Because you can see that your ScVO2 is containing blood from very important organs like brain, which is going to have a higher oxygen extraction compared to other organs. So that is the reason why your mixed venous oxygen saturation is relatively a little bit higher compared to the ScVO2. Suppose in certain conditions your ScVO2 may be more than your SvO2, which means your superior vena cava oxygen saturation may be more than your mixed venous oxygen saturation. What could be the reason? The reason could be either poor extraction of oxygen in the superior vena cava blood. So what are the conditions that can predispose to poor extraction of oxygen in the superior vena cava blood? Typically, in a patient who is in coma, where the brain utilization of oxygen is going to be very poor, patient is going to have a traumatic brain injury, again because of poor utilization of oxygen by the brain, and patient who is going for a general anesthesia, again because of poor oxygen utilization in the brain, or if a patient is having a shock. Clear? So in shock, the mechanism is a little bit different. It's not due to poor extraction in the brain, it is due to increased extraction of oxygen in IVC. So since IVC is causing increased oxygen extraction, that is because of two reasons. Because of splanchnic vasoconstriction, there will be diversion of blood away from the splanchnic circulation. So how can you tell that? Because the splanchnic circulation is the one, that mesenteric circulation is the one that gets, that extracts very, very low amounts of oxygen. So that is also one reason why IVC saturation is relatively higher than the SVC saturation. But here, since the blood is diverted away from the splanchnic circulation, your oxygen extraction will increase, because splanchnic circulation is going to extract less. If you divert it from away from the splanchnic circulation, your extraction is going to become more, because you are diverting to organs which are going to use more. So for that reason, your increased IVC extraction increased oxygen extraction in the IVC blood will be there, which means your IVC saturation will drop. Because your IVC saturation is dropping more, your SVC saturation is relatively higher, and that is the reason why it is more than the mixed venous oxygen saturation. So moment when they ask you when you will have your SCV saturation, that is your SVC saturation more than the mixed venous saturation, these are the causes that you have to tell. Clear? So again, the concept of oxygen delivery and oxygen extraction and all this SVC and IVC saturation and mixed venous oxygen saturation will be dealt once again in the shock chapter in detail. But right now, I just told you why you call this as a mixed venous oxygen saturation. So this is a very important video to give you a proper understanding on what you mean by SvO2, what you mean by ScVO2, and what you mean by IVCO2. SvO2 is a mixed venous oxygen saturation. ScVO2 is a superior vena cava oxygen saturation, and IVCO2 is an IVC oxygen saturation. All are different. Normally, your superior vena cava oxygen saturation will be definitely less than your mixed venous oxygen saturation, which means normally your SvO2 is the one that's going to be more than the ScVO2. If this thing is reversed and your superior vena cava oxygen saturation is more than the mixed venous oxygen saturation, you can interpret a lot of conditions, but the most important thing for a critical care physician is this entity called shock. So that is going to be the most important entity for as far as the critical care physician is concerned. So this is what you have to know as far as the oxygen hemoglobin decision curve is concerned. Clear? And still we have not answered our very basic preliminary question, that is why your PO2, the saturation, the PaO2 of 60 is considered as a critical PaO2. Let us see the answer for that. So usually the PaO2 of 60 corresponds to this point arbitrarily. So what does this matter? Why this point it should correspond, and why this should mean a lot? Because till this area the PaO2 drops, you will be here in the saturation. The PaO2 further drops, still you will be here in the saturation, not much dropping. Saturation is dropping by 1 or 2%, that's it. You come to 70 or 65, still you are in the OK zone. The saturation is not dropping that much. But the moment you come into the 60 zone, you are actually entering the steep portion of the curve. Any further drop in PaO2 below the 60 millimeters of mercury is going to have a drastic impact in saturation, which means after that the saturation is going to drop dramatically. So that is the reason often this PaO2 of 60 is what we refer to as something called a critical PaO2. Clear? So that is also one reason your definition of respiratory failure usually includes a PaO2 of 60, less than 60. So this is also forms one of the definitions of respiratory failure, because this PaO2 of 60 is so important to understand. Clear? So that is why I was explaining so many things here, to be honest. Clear? So let us move on. So let us move on to what do you mean by hypoxia now. So we have discussed enough about hypoxemia, and let us see what are the effects of hypoxemia. Suppose if the PaO2 goes below the critical value, so what are the effects of hypoxemia that you're going to get? So the first effect is going to be on organs. So a lot of organs that depend on this PaO2, that depends on this oxygen, and they have a high extraction ratio, are going to suffer first. The first thing I'm going to tell is on the heart, because this is the one that's going to have a very high metabolic demand and very high oxygen extraction ratio, and this is going to be, be affected first. And the first sign of hypoxemia is going to be tachycardia. The heart is crying out of tachycardia, and this tachycardia is going to reduce the diastolic time, and this reduced diastolic time is going to cause reduced LV filling, and reduced LV filling may further result in fall in the cardiac output. Remember, this tachycardia also causes reduced, not only this tachycardia causes reduced LV filling, the hypoxemia that is causing all these issues, this hypoxemia causing tachycardia may also cause reduced LV filling because of stiffening of the ventricles. So hypoxemia can cause stiffening of the ventricles, again the basic molecular mechanism being poor sodium potassium ATPase activity increasing the diastolic tension. Clear? Anyway, but anyway the hypoxemia is going to cause stiffening of the ventricles, and that itself may result in poor diastolic relaxation of the heart, resulting in reduced LV filling and further fall in the cardiac output. Okay. Second, your brain, one of the very important organs that have a very high metabolic demand, is going to be affected, resulting in something called an altered mental status. And number 3, your kidneys may also suffer from hypoxemia, resulting in oliguria. Oliguria of the kidneys may be due to many reasons. One reason you can attribute to reduced cardiac output because of reduced flow to the kidneys, and second, the hypoxemia itself can affect the kidneys, causing oliguria to have low function. Number 4, apart from that, you have tachypnea. Tachypnea is a very important sign of hypoxemia, obviously, because there is something called hypoxic hyperventilation reflex. Hypoxic hyperventilation reflex. So what is the mechanism of tachypnea trying to increase the oxygen, PaO2? So let us see an alveoli. This is a beautiful mechanism. Let us see an alveoli and let us put the same capillary system and the basement membrane. Clear? So now, as I told you, the one gas that is going to be affected by ventilation is CO2. Whenever you hyperventilate, the one gas that you are going to eliminate is your carbon dioxide. So let us assume you are eliminating a lot of carbon dioxide out. So why you are eliminating carbon dioxide? By eliminating more carbon dioxide, you are giving actually more space for oxygen. So which means you are trying to actually increase the partial pressure of alveolar oxygen by eliminating more and more carbon dioxide. How you can do that? Just simply see the alveolar gas equation also. It is nothing but your 713 multiplied by FaO2 minus PaCO2 by 0.8. Remember, the more you reduce the carbon dioxide, you are going to increase the alveolar oxygen. So by increasing alveolar oxygen, at least you can increase because the gradient will increase now. Obviously, if you increase the alveolar oxygen, the gradient will increase. That will try to increase the partial pressure of arterial oxygen. So which means somehow your hypoxemia might improve. So this is why you get a tachypnea. This is the reason why you are going to develop a tachypnea. This is what we also refer to as something called a hypoxic hyperventilation reflex. So this is such a beautiful mechanism, and anyway, it's a very simple and elegant one, so which you have to know. So these are some of the important things that you have to know about hypoxemia. But there is another entity called hypoxia itself, which you have not discussed at all. Let us see what do you mean by hypoxia. You have a lot of types of hypoxia. Before going into the respiratory failure per se, let us see some of the important types of hypoxia. Hypoxia means your impaired tissue oxygenation. That's it. Due to any reason. Hypoxemia is one of the reasons of hypoxia. That's it. So let us put something called first hypoxemic hypoxia. Previously, this hypoxemic hypoxia was also called as hypoxic hypoxia by older textbooks. Then you have anemic hypoxia. Then you have something called as stagnant hypoxia, or otherwise referred to as ischemic hypoxia, or even you can call it as a circulatory hypoxia. Finally, you have histotoxic hypoxia or a cellular hypoxia. So each and everything has a particular specificity. For example, the main problem in hypoxemic hypoxia is the low PaO2. So this is the primary problem in hypoxemic hypoxia, that is low PaO2. That is the one that is causing the hypoxia. In anemic hypoxia, stagnant hypoxia, histotoxic hypoxia, this PaO2 tends to be normal, absolutely. And what about the content of oxygen? Definitely in hypoxemic hypoxia it will be low because you are reducing the PaO2, which means you are definitely going to reduce the oxygen saturation in the hemoglobin, and definitely you are going to reduce the content of oxygen in the blood by reducing the oxygen saturation of the hemoglobin as well as your PaO2 reduction. In anemic hypoxia, surely it will be low because your hemoglobin itself is low in anemia. Because of that, surely you are going to have a low oxygen content because of low hemoglobin. Stagnant hypoxia and histotoxic hypoxia, the content of oxygen tends to be normal. Then what about your saturation? Saturation will 100% drop in hypoxemic hypoxia because I told you the saturation is totally dependent on the PaO2. Both are interlinked with each other. We have seen in the oxygen hemoglobin decision curve where your saturation is actually related to the partial pressure. So if it drops, obviously the saturation is going to drop. So definitely your saturation will be low here. But here you can see in all these conditions your saturation is normal, your partial pressure is normal, so definitely your saturation must be normal in all these hypoxias. And what about the cyanosis? Cyanosis is very common in hypoxemic hypoxia, and here also it's very common, but here it's very rare in anemic hypoxia and histotoxic hypoxia. One simple explanation what you can know is in anemic hypoxia, because you need at least a deoxyhemoglobin content of 5 grams per deciliter to produce cyanosis. But here in severe anemias, you may not even reach that 5 grams per deciliter of deoxyhemoglobin because the total hemoglobin itself may be only 5 to 7. So cyanosis becomes really rare in a patient who's having a severe anemia. You don't get a cyanosis, but you get all the features of hypoxia. And here something called an arteriovenous O2 content, oxygen content. Typically it will be decreased in case of a hypoxemic hypoxia. It again decreased in anemic hypoxia, tends to actually be increased in case of a stagnant hypoxia, and again decreased in case of a histotoxic hypoxia. The extraction is going to be poor in these cases. Clear? I mean AV difference, because the arterial oxygen content itself is reduced, so there won't be much difference in venous content. But in stagnant, because of the stagnation of the blood for a long time, the extraction is going to increase considerably. So that's the reason why the difference is going to be the maximum. It's going to be more in case of a stagnant or ischemic hypoxia. So what are the etiologies behind all this? Etiology wise, I mean hypoxemic hypoxia, any etiology that causes a type 1 respiratory failure or a type 2 respiratory failure or a reduced FiO2 states, that's it. Anything that causes a type 1 respiratory failure, anything that causes a type 2 respiratory failure, anything that results in breathing in low FiO2, like what I told you, the failure of the circuit or failure of your oxygen cylinders or whatever, so equipment failure, so anything that is in low FiO2 inhalation, so result in this hypoxemic hypoxia. So let us discuss, because we are going to discuss in detail about all these things. About anemic hypoxia, typically reduced levels of hemoglobin due to any cause, including blood loss, anything that causes anemia, fine. So then reduced available HB. So this is, you can tell, absolute reduction HB, or HB can be normal, but available HB may be reduced. That's also will come under anemic hypoxia only. So what are the conditions where you can have reduced available hemoglobin? Typically it happens in carbon monoxide poisoning. Carbon monoxide poisoning is an example of a anemic hypoxia only, because the available hemoglobin is actually less, which typically results from smoke inhalation. You can get something called a methemoglobinemia. Again here a lot of hemoglobin is in methemoglobin form. So the available hemoglobin to carry oxygen is less here. So that's the reason this is also one condition. So you can also get in patients who are having high affinity hemoglobins. Like again carboxyhemoglobin, high affinity hemoglobins, which does not release the oxygen at all. So these are three classic conditions, but you will think only about anemia causing absolute low levels of hemoglobin, but even reduced available hemoglobin, these patients also will be coming under anemic hypoxia only. What about stagnant hypoxia? Typically in any patients with heart failure or shock or a vessel thrombus like stroke, MI, all these things will come under stagnant hypoxia or circulatory hypoxia or ischemic hypoxia. What about histotoxic hypoxia? Best example is cyanide poisoning, where it's a cellular level hypoxia. Everything in the blood will be normal, only the cellular level they cannot utilize the oxygen. So we have discussed in detail about the cyanide poisoning already in our hematology section. So no need to discuss again all these things here. So these are some of the examples. These are really important for exams. All these values they might be asking you in exam. So think about this and please do remember all these things. Very easy to remember. So no need to mess it up. Clear? So these are the types of hypoxia you have. Now let us move on to the respiratory failure per se. So basically you have four types of respiratory failure. You have a type 1 respiratory failure, you have a type 2 respiratory failure, you have a type 3 respiratory failure, and you have a type 4 respiratory failure. Type 1 respiratory failure, let us see what are the other names for this. Type 1 respiratory failure is also referred to as hypoxemic respiratory failure. Type 2 respiratory failure is also referred to as hypercapnic respiratory failure. Type 3 respiratory failure is also referred to as perioperative respiratory failure. And type 4 respiratory failure is also referred to as something called a shock-related respiratory failure. Clear? So what is the mechanism of type 1 respiratory failure? The major mechanism is low partial pressure of arterial oxygen, low PaO2. This is the primary reason. This is the primary problem in hypoxemic. That's the reason it's called hypoxemic respiratory failure. This low PaO2 may result from any condition, reduced ventilation, reduced oxygenation, or it could be due to reduced perfusion or VQ mismatches, shunt formation, anything that causes low PaO2. Obviously, it's going to trigger your hypoxemic hypercapnic reflex, hypoxemic hyperventilation reflex. So you are going to go for hyperventilation. The moment you do the hyperventilation, you are going to wash out your carbon dioxide level. So your PaCO2 will drop. Always remember, this low PaCO2 is done in an attempt to increase the partial pressure of alveolar oxygen, so that you might, push in more oxygen to increase the partial pressure of arterial oxygen. So that is the idea which you have discussed already. So this is something very important to do. Because of that only you increase the arterial oxygen. Clear? And this decline in the partial pressure of arterial carbon dioxide is going to act as a secondary mechanism and not a primary thing. So this is a secondary thing. This is in response to this low PaO2 only. So this is not the primary event that is happening. This is a response event to hypoxemia. Clear? Do you understand? So that is why the definition of type 1 respiratory failure means a PaO2 of less than 60 millimeters of mercury plus a PaCO2 of less than 35 millimeters of mercury definitely tells you it's a type 1 respiratory failure. So low critical PaO2 plus a low PaCO2, surely it's a type 1 respiratory failure. Clear? Okay. What is hypercapnic respiratory failure? Hypercapnic respiratory failure, the main problem is elevated PaCO2. Elevated PaCO2. I already told you, by your alveolar gas equation, which must be this, your PaCO2, if is going to elevate, obviously your alveolar oxygen is going to drop, which means automatically your arterial oxygen also will drop because of the drop in the gradient. As simple as that. Clear? So this high PaCO2 is going to result in fall in the PaO2, which means the primary problem here is going to be the high PaCO2. That is why we are going to call it as a hypercapnic respiratory failure. Clear? So what could be the potential definition of this hypercapnic respiratory failure? The first thing is the PaCO2 more than 45 millimeters of mercury, which is more than normal, plus your PaO2 is less than 60 millimeters of mercury. So this you can call it as a type 2 respiratory failure. But certain textbooks are going to give you this value as less than 75. That doesn't mean anything at all. So, but I follow this 75 or 60 depending on the clinical circumstance. Again, medicine is all about how you interpret. The most important thing in medicine that you need is the logic. And the second most important thing that you need in medicine is the common sense. It's not about the values. It's not about what you do. It's always about what you're going to do from here. It's all about the common sense. So if the patient is very sick, less than 75, I'll take it as a respiratory failure. If the patient is not, very sick, I might take even less than 60 as a respiratory failure. So it all depends on my common sense. That's it. Anyways, it's not about the books that are wrong. It's the interpretation that is wrong most of the times. Okay. So let us move on to the type 3 respiratory failure. What is going to be the type 3 respiratory failure? It's a perioperative respiratory failure. So it is due to your atelectasis. There is something called a post-op atelectasis usually. That is the reason why you get this type 3 respiratory failure. It is actually considered as a subtype of type 1. Subtype of type 1 respiratory failure. So usually this atelectasis will have a background. It is due to neuromuscular weakness. Neuromuscular weakness. This neuromuscular weakness will precipitate to type 2 respiratory failure. This atelectasis means it's a type 1 respiratory failure. The combination becomes a type 3 respiratory failure. So that is the reason why it is considered as a type 3 respiratory failure. But typically, they are initially put under a type 1 respiratory failure. But in general, we are going to now currently call as type 3 respiratory failure, the peri-op atelectasis. It is due to a combination of the collapse, which is actually due to the neuromuscular weakness, maybe due to excessive use of neuromuscular blocking agents, the patient old age, or the patient's severe comorbid factors may be hindering in the patient's improvement from general anesthesia and this neuromuscular blockade. So they might go for this atelectasis of certain lung segments, resulting in poor expansion, and they might result in type 1 as well as type 2 respiratory failure causing this classic type 3 respiratory failure, which is nothing but a post-op atelectasis. And type 4 is going to be shock related respiratory failure, which means this failure, respiratory failure, is going to result from cardiovascular instability, which is going to cause reduced perfusion to the respiratory muscles. Because of that, they can't breathe properly. So this is what we refer to as something called a type 4 respiratory failure. Clear? So in general, type 1 respiratory failure is hypoxemic, type 2 respiratory failure is hypercapnic, type 3 is perioperative atelectasis, and type 4 is shock related respiratory failure. And the most important thing that we need to know is type 1 and type 2 for all practical purposes, because this type 3 and type 4 is not a very big deal. For all practical purposes, what is needed for our practice as well as in ICU critical care is the type 1 and type 2 respiratory failure. So now let us move on to the type 1 respiratory failure. So what do you mean by a type 1 respiratory failure? And because we need to know the causes, we know the definition of type 1 respiratory failure, that PaO2 low, which should be less than 60 as per definition, and at the same time you might have a low PaCO2. Clear? This is supposed to be the definition of a type 1 respiratory failure. Anything less than 35 you can call as a type 1 respiratory failure. We know that the primary thing is the low PaO2. What is the cause of this low PaO2? If you ask me, I will tell you the low PaO2 causes may be very, very few. The first thing I'm going to tell is your VQ mismatch. And the second thing I'm going to tell is something called a shunt formation. A shunt formation. So what do you mean by VQ mismatch? The moment I call VQ mismatch, the VQ mismatch, which means the VQ ratio is increasing or decreasing. A VQ ratio can be decreased, which means it's less than 1, or VQ ratio can be increased, which is more than 1. The moment I called shunt formation, which means the VQ ratio will be is equal to 0. Let me come back to that. What are the mechanisms? Let us put the alveoli. Let us put the capillaries over here, and let us put the base membrane. Okay. Now, what is this classic type 1 respiratory failure due to decreased VQ ratio or due to VQ mismatch? Before that, let me duplicate this, because we are going to use the same mechanism for the other two as well. I mean, similar kind of mechanism and similar kind of diagram. That's what I'm trying to tell. Okay, let us come back. So, what do you mean by VQ more than 1? Which means this is the ventilation, and you can see this is the perfusion. If I tell VQ is less than 1, means my ventilation is low. That is the reason why numerator is decreasing and the denominator may not change much. That is the reason my ratio is becoming less than 1. So what are the conditions that can reduce the ventilation of the alveoli? Very, very, very simple fact, that is going to be airway obstruction. Any airway obstruction is going to result in type 1 respiratory failure only. Very important point, because it's a common myth knowing that airway obstruction results in type 2 respiratory failure. Not at all. I'll tell you what and when the airway obstruction results in type 2 respiratory failure. But right now, stay with me. Airway obstruction is a type 1 respiratory failure only. So what are the examples? Obstructive lung disease. Any obstructive lung disease which I have seen in a great detail in pulmonary function testing. You have bronchial asthma, acute attacks of bronchial asthma, definitely a type 1 respiratory failure. COPD, definitely a type 1 respiratory failure, especially emphysema. And your cystic fibrosis, bronchiectasis. So any obstructive lung disease you take is going to be a type 1 respiratory failure only. Clear? At the same time, you have interstitial lung disease. Interstitial lung disease, even though this is something which is very important to be understood, in ILD there are two mechanisms that are operating for hypoxemia. In ILD, interstitial lung disease, there are two mechanisms that are operating. One is called your diffusion limitation. One is called a diffusion limitation, and second one is VQ mismatch. VQ mismatch. So diffusion limitation contributes to only 20% of the level of hypoxemia you're seeing, and the VQ mismatch is going to be the one that's going to contribute to 80% of the hypoxemia that you see in an ILD, which means even though the diffusion limitation is characteristic of ILD, it's going to be absolutely characteristic for ILD, diffusion limitation, perfectly characteristic, absolutely characteristic for ILD. This VQ mismatch is the most common reason for hypoxemia in ILD, most common mechanism of generating a hypoxemia in ILD. It's a very, very important point. ILD means diffusion limitation always. I'm not telling that's the case. Clear? There might be a certain character that defines a person. First of all, there could be Sachin Tendulkar means batting. He defines batting. It doesn't mean he's doing batting 24/7. He has its own life. He does a lot of other things as well. So you can remember like the diffusion limitation is characteristic of ILD. It is the hallmark of ILD, but it is not the most common and major mechanism for hypoxemia. And ILD, you might ask me how they can result in airway limitation. It's because of a lot of other principles like dynamic airway compression, where ILD patients do have poor oxygen influx into the alveoli. In part, they are having a restriction because of their lungs do not expand properly. Because of that, the oxygen entry into the alveoli is also less. That also you can think about. But anyways, in whatever way you think about this, VQ mismatch is the most common reason for hypoxemia in ILD, even though diffusion limitation is characteristic. Clear? These are the two things that you have to know. Then when your VQ ratio is going to be more than 1, which means here you have ventilation, here you have perfusion. What if I tell your perfusion is low? Because of that, your VQ ratio becomes more than 1. Let us see as an example. Here, if the denominator decreases, numerator is the same, your ratio is going to increase for sure. So which means what are the conditions that are going to cause low perfusion? Typically, any condition that produces pulmonary hypertension. For example, you can have a pulmonary embolus, you can have an example of a Eisenmenger syndrome. Any example you can tell for a pulmonary hypertension is going to cause a VQ ratio of more than 1. In that, this particular pulmonary embolism is very, very notorious, which can cause a VQ ratio of even a infinity. Why? Because in massive PEs, for example, in a massive pulmonary embolism, the perfusion becomes literally 0, and anything divided by 0, you're going to get infinity. As simple as that. Clear? Okay. So the next thing what you can think is about any kind of cardiogenic shock, especially your right ventricular failure, where you are going to get a reduced pulmonary blood flow because of that reduced perfusion. So any kind of cardiogenic shock in special, you can think about the right ventricular failure, but anything that causes cardiac failure, even left heart failure is a condition that produces low pulmonary blood flow. So definitely a VQ ratio is going to be more than 1 for sure. Clear? So these are some of the examples, but we didn't discuss anything about the shunt formation. So what do you mean by shunt formation? What do you mean by VQ of 0? Which means what if I tell this alveoli is dead completely? This is non-functional, which means ventilation is equal to 0, but perfusion is happening. So which means 0 divided by perfusion is equal to 0, which means here the ventilation perfusion ratio is 0. And what is happening really here is the blood that is coming from the right side bypasses this alveoli and moves to the other side and enters the pulmonary veins on the left side, which means on the right side also you have deoxygenated blood, which is quite normal. On the left side also you have deoxygenated blood because this alveoli is completely dead. This alveoli is not going to transfer any oxygen at all. So the blood that is coming from the right side is directly pushed to the blood on the left side, which means you are mixing with other blood that are actually coming oxygenated, and you are mixing this deoxygenated blood along with the oxygenated blood that are coming from the other alveoli. This is what we refer to as shunt formation, and this is a typical example of a physiological shunt. Clear? So which means what do you mean by a shunt formation? Anywhere you mix an oxygenated blood with a deoxygenated blood, that is equal to shunt. It could be physiological or it could be anatomical. Let us see what are the causes. So whenever you talk about the shunt formation, I can tell two types of causes. One is called an anatomical shunt formation and second one is a physiological shunt formation. Physiological, even though, tends to be the most common. Anatomical shunt formation, you have a lot of anatomical causes. Number one, you have intracardiac causes, which you are very, very familiar with. Your any cyanotic congenital heart disease is an example of an intracardiac shunt causing cyanosis and blood shunting from right side to the left side directly. Similarly, an acyanotic heart disease also can cause intracardiac shunting once they develop your Eisenmenger syndrome. Clear? Once they develop Eisenmenger, they also become they behave like a shunt only. So then second, you can have something called an intrapulmonary shunt. Your intrapulmonary shunt typically happens with pulmonary AV malformations. So where pulmonary artery is connected to the pulmonary veins, where the blood from the artery is directly shunted to the pulmonary veins. But there are some natural shunting that is happening along the bronchial veins to the pulmonary veins, but I don't think that is going to cause any impact clinically, but this pulmonary AV malformation is a pathological thing, that's all. What are the examples of physiological shunting? See, whenever you have a physiological shunting, there are a lot of processes that can result in this physiological shunting. Like for example, let us see there are something called a bilateral diffuse alveolar filling process. That's number one. Or you can have a massive collapse. So let us see the number one, that is bilateral diffuse alveolar filling process. You have something called a bilateral diffuse alveolar filling process. What do you mean by that? You have an alveoli. You know this alveoli is going to be dead and buried, and it's not going to take part in anything. But please do remember, what is the reason why this alveoli is dead and buried? It could be filled with something. That is what you call it as alveolar filling process. What could be filled? You can fill it with water, which we call it as pulmonary edema. So in a very, very extensive, remember the shunt formation means it's very severe. It's going to be extensive, not a normal simple basal Cribs induced pulmonary edema, not like that. It's going to be very severe, extensive pulmonary edema. So it could be either a cardiogenic pulmonary edema, or it could be a non-cardiogenic pulmonary edema as well. Non-cardiogenic pulmonary edema is what we refer to as ARDS, acute respiratory distress syndrome. Then this filling could be with blood. For example, you can tell a diffuse alveolar hemorrhage, which typically happens in vasculitis like Goodpasture syndrome, vaginous granulomatosis, microscopic polyangiitis, and all these things, or even in SLE, diffuse alveolar hemorrhage. Or this could be filled with pus, with a massive pneumonia, like a very big pneumonia, not a small pneumonia. Obviously, shunt formation is going to be extremely severe. So a massive pneumonia can result in a shunt formation like this. So shunt formation means it should be very, very severe. Bilateral diffuse alveolar filling process. Number one, cause. Number two, you can get in a massive collapse. Massive collapse. What are the conditions that causes massive collapse? Which means the moment I call shunt means it should be really big, especially the physiological shunt should be so big to produce. Like real hypoxemia and real danger. Like small shunting will not cause any problem. At least, like at 50 to 60% of the blood should mix, which means it should be huge. 50 to 60% of the lungs on both sides should be involved. Then only you will get this severity, like otherwise it won't be severe at all. Please note that. So what are the examples of massive collapse? Usually conditions that cause massive collapse will be unilateral most commonly. I'm not telling always. Most commonly it will be unilateral. How I told you, this diffuse alveolar filling process will be bilateral most commonly. Like that, your massive collapse will be most commonly unilateral in location. So what are the examples of massive collapse? For example, you can have a lung like this. For example, what if you have done something called an endobronchial intubation? So this endobronchial intubation is a very, very, very common cause of a massive collapse, which is very common as a beginner, right? So this lung is going to completely collapse, and obviously all the blood is going to shunt to the left side without getting oxygenated from this lung, because the endotracheal tube is only aerating this particular lung. So this can happen, or this massive collapse can be due to accumulation of something else, right? This something else can be a massive pleural effusion or a massive empyema, again massive empyema, or could be a tension pneumothorax. Tension pneumothorax. Or it could be due to a occlusion by a mucus plug. So all these causes are very common, and it is actually easily rectifiable if you identify them early. So this is one condition that causes massive collapse, and because of that you get a shunt formation, because of that you might get all these issues. And the third example, which may or may not be severe, and one of the classic examples of shunt formation is hepatopulmonary syndrome, HPS. We'll discuss in great detail about HPS, hepatopulmonary syndrome, where you have to differentiate between two pulmonary effects of portal hypertension, that is portopulmonary hypertension versus hepatopulmonary syndrome. What really happens in hepatopulmonary syndrome? I'll tell you in a nutshell. This is the alveoli, and let us zoom the capillaries that are going to travel. This is the right side, you get a deoxygenated blood, and the left side you have to get the oxygenated blood. So, but what happens is here there will be too much vasodilation, too much of vasodilation. The main problem in hepatopulmonary syndrome is vasodilation, too much of vasodilation, that when oxygen is coming from the alveoli, they are going to oxygenate only the RBCs that are traveling on the some of the portions of the capillaries. The RBCs that are traveling a little bit away from the capillaries are not going to be oxygenated, and they are going to directly shunt on the left side, which means you are shunting the deoxygenated blood with the oxygenated blood, because these are oxygenated blood that are mixing with the deoxygenated blood, and again it's a classic example of a shunt formation. So that is due to severe vasodilation, and you are not sufficiently causing oxygenation of the certain columns of blood that are traveling because of massive vasodilation that happens in hepatopulmonary syndrome. So HPS, hepatopulmonary syndrome, is again a classic example of shunt formation, which can be severe or which need not be severe. So these are very important causes of type 1 respiratory failure. So your main idea in type 1 respiratory failure is to differentiate between this VQ mismatch and shunt formation. You don't have time in your ICU, so you have to do that very fast, because the treatment is going to be very different, which I'll tell you. So how are you going to differentiate? This is called 100% oxygen test or hyperoxia test. You are going to give 100% oxygen to the patient. Remember, if it's a VQ mismatch, they definitely improve with 100% oxygen. They surely improve with 100% oxygen, which means your PaO2 will become more than 60 instantaneously. If it's going to be shunt formation, your PaO2 will still remain less than 60, and it will be completely resistant to your excessive oxygen administration. So you are not going to have any improvement with 100% oxygen. So this is the major practical clue in ICU to differentiate from a VQ mismatch versus shunt formation. Very important. Remember, a pneumonia can cause a VQ mismatch also. Pneumonia can cause a shunt formation also. Pulmonary embolism can cause a VQ mismatch, and the pulmonary embolism, if it's severe enough, it can cause shunt formation. It all depends, on in what way you're going to manage. It's all depends. Obviously, I'm not telling this disorders will cause only this. I've told you some classic examples for particular thing, but anything can cause anything in ICU and in real life. So be very sure about that. Clear? So this is a very important test. If you have a shunt formation, it won't respond to 100% oxygen. For sure, still the PaO2 will remain less than 60, and it's an indication for intubation. We'll see in the management part. Clear? Fine. So now we have seen all the causes of type 1 respiratory failure. So now let us see the causes of type 2 respiratory failure. So type 2 respiratory failure, it's a hypercapnic respiratory failure where your PaCO2 tends to be more than 45 and PaO2 tends to be less than 60 to 75. Clear? So I told you about this fact already. Fine, but this is the most important thing. So why your PaCO2 is increasing? Because of poor ventilation, which means your minute ventilation is decreasing. That is what we refer to as hypoventilation. And the reasons for your minute ventilation to decline may be either a reduction in the tidal volume or a reduction in the respiratory rate. Those patients whose tidal volume is reducing, we call them as patients who can't breathe because of diaphragmatic weakness, because these people tend to have a diaphragmatic weakness. And those patients who have low respiratory rate are these patients who are going to not breathe, won't breathe patients. And these patients are going to have central issues. Clear? So let us see the causes based on this. So let us see the patients who won't breathe first. What will be the characteristic features of patients who won't breathe? And what are the characteristic features of the patients who can't breathe, which means they have diaphragmatic weakness. These patients who have diaphragmatic weakness, again you can categorize into two. Typically they have neuromuscular paralysis on one side, and those patients who go for respiratory fatigue. Sometimes because of too much of work of breathing, your muscles may go fatigue, because of that you can't breathe. Simple. So respiratory fatigue. So what are the etiologies of patients who won't breathe? Typically I told you these are going to be central causes like your brainstem lesions, or could be due to over sedation from narcotic agents or benzodiazepine poisoning, a lot of morphine intake, any over sedation causes, or it could be due to any encephalopathy, head injury, raised ICP states, anything that causes raised intracranial pressure, causing typically tonsillar herniation. Example I'm telling you, all these things are going to be central causes of hypoventilation, where the respiratory center is not producing the drive for respiration. That's why they are not breathing. I won't breathe. I can't breathe, which means I wanted to breathe but I can't because my muscles are weak. So what are the conditions? So typically you have neuromuscular weakness, neuromuscular paralysis. Best example you can tell from the spinal cord. In the spinal cord you can tell MND or polio. Then you can come to the peripheral nerve, where you can talk about Guillain-Barré syndrome. Then you can come to the neuromuscular junction, where you have some typical example of a myasthenia gravis, especially during crisis situation where they have respiratory failure. And when you come to the muscles, I mean in the neuromuscular junction itself you can tell the neuromuscular blocker toxicities. When you come to the muscle, as such you can tell a lot of myopathies at end stages, and muscular dystrophies also they cause death due to respiratory failure because they can't breathe. That's the idea, and type 2 respiratory failure only. So the classic examples, I'm not telling everything, these are typical and classic examples. Okay, fatigue. This is a very tricky scenario. Remember, fatigue can happen due to severe obstruction. That is the idea. Don't think obstructive lung diseases will cause type 2 respiratory failure all the time. Only if the obstructive lung diseases are severe enough, or if the obstruction is fixed and it's there forever. So you might go on to a type 2 respiratory failure. So for that instance, even a type 1 respiratory failure can go to a type 2 respiratory failure. Let me tell you the mechanism. Let us assume I am having an upper airway obstruction. Somebody is obstructing here to me. Now, actually my work of breathing, the more proximal I have the obstruction, my work of breathing will increase. Remember, if my obstruction is here, somewhere in the periphery, I will not suffer so much. But if my obstruction is here, actually my work of breathing will become so much high actually. I don't know how to explain. The more proximal the obstruction, the work of breathing is going to be so much. That's the reason any upper airway obstruction is going to produce very fast fatigue, because I'm going to, it's very difficult to breathe in. You can try yourself if you want, if you're daring enough. So upper airway obstruction, very fast fatigue. That's the reason when you suicide and all, apart from, causing a lot of other, reduced blood flow to the brain, you obstruct the airflow. It's very difficult to breathe with, obstruction in the upper airways. It's going to fatigue very fast, and you're going to, stop breathing very fast because diaphragmatic paralysis. So upper airway obstruction, anything upper airway obstruction. Best example you can tell is acute epiglottitis or any foreign body in the upper airway. Very difficult to breathe. The child goes for very fast fatigue and they die. That's why it has to be treated very fast. And typically during COPD exacerbation. COPD exacerbation. Remember, COPD exacerbation typically causes the type 2 respiratory failure. Let us see how they behave normally. You have three disorders like bronchial asthma, emphysema, and a chronic bronchitis. Chronic bronchitis. Three disorders are there. Remember, and how chronic bronchitis during normal states, how they behave, and during exacerbation, how they're going to behave. So during normal times, chronic bronchitis will not have any respiratory failure. First of all, you have to understand that bronchial asthma will get respiratory failure only during, like your acute attacks. Apart from that, you don't have any problem in bronchial asthma. Emphysema typically behaves like a type 1 respiratory failure because it's very classical example of a diffusion limitation, which I have discussed already. And chronic bronchitis is going to typically behave like a type 2 respiratory failure at baseline because these patients tend to be very obese and they don't breathe at all most of the time. So that is the main reason why these patients will typically go for a type 2 respiratory failure. And bronchial asthma during exacerbation behaves like a type 1 respiratory failure because it's obstructive. Emphysema again in early and late is there. During exacerbation, again they come like a severe type 1 respiratory failure, but in late stages of exacerbation they go to a type 2 respiratory failure because of the fatigue. Why these emphysema patients are prone for fatigue? Because these emphysema patients are having type 1 respiratory failure, which means they will be tachypneic at rest itself. That's a very important point. They will be tachypneic at rest. Because they are tachypneic at rest, lot of energy and your basal metabolic rate will be spent on your tachypnea itself, which means these patients will be severely cachexic. At the same time, they will have poor muscle function. Your muscles will be deconditioned, they won't have a proper muscle power, including respiratory muscles. That is why during exercise period they cannot tolerate that excessive workload and easily they go for fatigue. Very simple fact. That's because they will be cachexic and poor muscle tone and muscle function, deconditioned muscles, because a lot of energy in BMR is utilized for this tachypnea, which they are doing daily continuously. During exercise period, they cannot make it up. They go for fatigue very fast. That's why emphysema. Again, obviously chronic bronchitis, there is no doubt, even in exacerbation or even in normal state, they'll behave like a type 2 respiratory failure. They'll be sleeping all the time. That's what CO2 narco. This is a very important thing to understand. So COPD exacerbation is a very tricky scenario where the patient will go very fastly to your type 2 respiratory failure. So you have to be very careful, especially in emphysema patients. They can go very fast to type 2 respiratory failure because of fatigue and exhaustion. And the patient is having a severe metabolic acidosis, because again metabolic acidosis, the work of breathing is very high, because I told you there will be Kussmaul's breathing where there will be deep and rapid breathing, which increases the work of breathing dramatically. So that's what happens. So clear? So these are the conditions that produces type 2 respiratory failure. And what are the patient characteristics that you can able to differentiate? First, see the work of breathing. Remember, in a patient who is having a central hypoventilation, work of breathing will be normal per breath. I am talking about per breath. Per breath, the work of breathing will be normal, because they breathe normally. I mean, the volume, tidal volume will be normal in them, only they don't have the proper respiratory rate because the drive is lost, but the work of breathing will be normal. Whereas the neuromuscular paralysis, the work of breathing will definitely be reduced because they cannot take sufficient tidal volume. But here it will be very, very high, because it's a sign of a fatigue, which means they are breathing so fast and deep, and they are not able to cope up with that. So it's a sign of fatigue. So work of breathing will be very high, because it's something like it's an exhaustion related type 2 respiratory failure. So the work of breathing has to be high to cause that exhaustion. So work of breathing will be high. That's what we have been talking about. And whether the patient will have any obvious dyspnea. Obvious dyspnea, definitely no. But here also no. But definitely yes. Patient who is going to go for exhaustion definitely will have obvious dyspnea. Severe dyspnea, they will feel they'll be very bad and they'll go for fatigue. So that's the idea. But these two patients will not have any obvious dyspnea. And what will be the mental alertness, mental state? This patient will be drowsy, obtunded, even comatose. Mental state will be very down. Obtunded, stuporous, comatose, you can tell anything, but the mental state will not be good. Here the mental state typically normal. Here most of the time they tend to be very, very agitated because, for example, take an airway obstruction, somebody is obstructing here, you will be very cool or what? Definitely will be agitated. So many of the times patients are going for exhaustion, they will be severely agitated because they are not able to breathe, it's like suffocating them. So definitely they will be agitated. And then you can see about what is the basic pathophysiology. Pathophysiology wise, here it is the reduced respiratory rate, here it is the reduced tidal volume, here it is complex causes. Typically it is due to increased dead space formation, reduced tidal volume and formation of shunt. All these things can result in exhaustion. Remember, and very importantly, a type 1 respiratory failure patient, because of fatigue, if you don't treat, without treatment, definitely because of exhaustion fatigue, they will go for type 2 respiratory failure. You have to be very careful. So fatigue may not happen only in these circumstances which I told. It can happen in any type of respiratory failure patient who have not been treated sufficiently. If you are, like treatment is inadequate or the patient presents very late, they can come in a fatigued state. You can go for a type 2 respiratory failure, especially in acute situations. Clear? So these are the conditions that you have to know. Yeah. What is the CO2 relationship with your mental state? Suppose if PCO2 is less than 80, which means a pH of more than 7.2, means the patient will be very stable, mentally not much problematic. If PCO2 levels keeps on increasing to a level of 100 to 120, which means pH becomes less than 7.2, they'll go for CO2 narcosis. So this is the typical time where they'll go for CO2 narcosis, where they'll go for complete somnolent state, and they'll have an altered mental status. They'll be full time sleeping, and the respiratory rate and drive will further fall. I told you this 70 to 80 is the threshold for respiratory drive. Up to 70, 80, your respiratory drive will actually increase, but after 80, your respiratory drive paradoxically will decrease. So that they'll go for CO2 narcosis. Clear? PCO2 of more than 120 to 130, which means the pH will drop to less than 7.1, will result in a comatose patient completely. They'll be knocked out, they'll be in coma. Clear? Again, these are very important values, at least for exams. Fine. We are coming to the end of the respiratory failure session, which I'm going to tell everything in a nutshell, including the treatment. So how you are going to see this respiratory failure as a whole, and you're going to treat. Okay. The first thing what I'm going to see is whenever the patient is having a suspected respiratory failure. So anyone, for example, patient is having increasing shortness of breath and dyspnea, patient is having a falling saturation. These are some indicators. Patient is having a falling saturation, or a patient is having a falling PaO2 in ABG. So all these things are some of the examples of, when you can suspect a respiratory failure. Whenever you suspect a respiratory failure, the next step you have to do is to take an ABG and see the A gradient. So you take an arterial blood gas and see the A gradient. See whether the A gradient is more than 12 or if it's less than 12. Some books will give you this cutoff as 30 also, but it's okay. Less than 12 or more than 12. So if it's more than 12 means it's increased, less than 12 means it's normal. If it's more than 12, it's increased. Typically, I'm going to think about type 1 respiratory failure and diffusion limitation. Diffusion limitation alone. How to differentiate this? Ask when the patient is having dyspnea and falling saturation. So at what time? So falling saturation and dyspnea, which means it happens only at exertion or only at exercise, which means even by walking they get a falling saturation and they get dyspnea, or it happens at rest itself. That's what I'm going to ask. If it happens at rest, it's definitely a characteristic type 1 respiratory failure. If it happens only at exertion, which means I'm talking only at exertion, then it means a characteristic diffusion limitation. The two diseases which I'll be thinking about diffusion limitation is emphysema versus ILD, which I told you already. If it happens at rest itself means it's something little bit severe and they have entered a type 1 respiratory failure algorithm. So whenever you have a type 1 respiratory failure, you have to ask a question. Now the question is between VQ mismatch versus a shunt formation. How you are going to tell whether it's a VQ mismatch or a shunt formation? You have to go for a trial of 100% oxygen. Already I told you. If the PaO2 now becomes more than 60 or the PaO2 still remains less than 60. The PaO2 now becomes more than 60, definitely it's a VQ mismatch. And if PaO2 is still less than 60, it definitely indicates a shunt formation. If it's a VQ mismatch, please address the cause. That's very important. And since your PaO2 becomes more than 50, remember in respiratory failure, target PaO2 always is just more than 60. That's all. In ICU settings, it's very important to understand. You have to just maintain a PaO2 of more than 6. That's nothing else. Don't be over ambitious. You're not going to reach 100, 200. Just more than 60 is more than enough to at least save the patient, and it's enough. Otherwise, you will result in other problems like hyperoxia injury and all. So it's don't be over ambitious. More than 60 is more than enough. So since oxygen itself is giving rise to a PaO2 of more than 60 in these patients, so continue oxygen therapy, but try to reduce the oxygen and keep a oxygen at a very low level that maintains a PaO2 of more than 60. That's all, nothing else. So continue oxygen therapy and address the cause. If it's a pneumonia, treat the pneumonia. If it's pulmonary embolism, treat the pulmonary embolism. If it's an obstruction, treat with nebulization and all the bronchodilators and all. So the moment you know it's a shunt formation, remember, the ideal treatment, if they ask you, the next step, if they ask you for shunt formation, you have to go for positive pressure ventilation, PPV. That's it. Either intubation. Positive pressure ventilation is of two types. Either you can go for NIV, non-invasive ventilation, or you can also call it as NIPPV, non-invasive positive pressure ventilation. Both are the same. Or you can go for a mechanical ventilation through endotracheal intubation. We call ETT. Clear? So both are possible. Invasive ventilation or non-invasive ventilation. Both you can try. But the next step, you have to go for PPV. This is the next step. But still you can tell the causes. Because remember, the physiological shunts are more common than anatomical shunts in ICU, because you don't encounter anatomical shunts that commonly. How many ICUs will encounter daily your TOF or your transposition of great vessels as a cause of hypoxia and hypoxemia? No, we encounter only physiological shunts. Very, 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 very common is the physiological shunt. That too, the first two processes that are very common, that is your bilateral alveolar filling process and your massive collapse on one side. So these are going to be the classic most common causes of shunt formation. Clear? So that's what I'm trying to find it out. So I'm going to do a proper clinical examination. C means clinical examination, plus I can do a simple chest x-ray if I want. But if I don't have time, remember, if I don't have time for all those, patient is dying, please initiate a positive pressure ventilation as soon as possible. This is for analysis, I'm telling you. Do a clinical examination and a chest x-ray. If the pathology is bilateral and diffuse, I'm going to go for, it's a bilateral alveolar filling process. So definitely next step, I have to initiate PPV. Here remember, the idea of giving PPV is not oxygenation. If the patient is oxygenating with your routine techniques, means he has to oxygenate with 100% oxygen itself. If he's not oxygenating, means the idea of giving PPV is to open up the collapsed alveoli. Here the alveoli are filled and it's collapsed. So you are trying to open up the collapsed alveoli so that you are filling this with air and you are improving the oxygenation. That is the idea of positive pressure ventilation. Remember, the idea of positive pressure ventilation is not to cause the oxygenation, it is to open up the collapsed alveoli. That is the idea. Please do understand. Idea of PPV is not to oxygenate the patient. Clear? Not for the oxygen delivery of the patient. It is to open up the alveoli so that the oxygenation automatically improves. Please be very careful about that. And then you have unilateral process that is affecting typically one particular area of the lung. In this condition, which means it's very likely to be a massive collapse. Unilateral massive process. There is likely to be a massive collapse. And whenever you have a massive collapse, it's very easy to treat the underlying cause. Treat the underlying cause. Most of the time, remember, it's very easy to treat the underlying cause, at least for temporary time being. because you have to address causes like endobronchial intubation, because what you will do in endobronchial intubation, you are just going to adjust the tube. You have to pull it and reinsert again, that's it. Or just pull a little bit out, you are going to treat it. And if it's a mucus plug, just you have to do suctioning, that's it. Maybe if it's very deep inside, you have to go with the bronchoscope and you have to take the plug out through the endotracheal tube itself. Or like then you have tension pneumothorax, or if it's a massive pleural effusion or an empyema, massive pleural effusion or an empyema, here you are going to do needle thoracocentesis. In both these conditions, you are going to do emergency needle thoracocentesis plus ICD insertion, intercostal chest drain. I mean, I should not call ICD because these should be called as chest drains as per the current nomenclature. But I can call ICD, I will take it for granted. It's intercostal chest drain, but just call chest drains. I mean, according to the current, because we are old people and we usually tend to call ICD because ICD means currently implantable cardioverter defibrillator. But currently we should not call ICDs, we should call these as chest drains only. So easy. Massive collapse in ICU, very easy to treat. So this is how you are going to treat. If still not responding, I mean, obviously you have to go this also for PPV only, positive pressure ventilation, but very difficult to treat unless until you take the underlying cause out. How, I mean, tension pneumothorax, remove that, then only the patient will get better. What is the point in giving PPV? You can inflate the lung to an extent, but you have an air there, like you have to remove that first. That's the idea. So please be very sure about that. So these are the ways how to treat a type 1 respiratory failure in your ICU setting, and to understand the type 1 respiratory failure. Remember, whenever your A gradient is less than 12, which means if the A gradient is supposed to be normal, so what are you going to do? You are going to do something called a PaCO2 analysis in the ABG. So PaCO2 can be low, which means the patient is hyperventilating, or PaCO2 can be high, suggestive of alveolar hypoventilation, which means it is suggestive of a type 2 respiratory failure predominantly. If PaCO2 is low, means it indicates patient is breathing low FiO2, which means it's a low FiO2 state, which means patient is probably having a circuit failure or equipment failure and try to correct that. If PaCO2 is increased and the patient is having alveolar hypoventilation, what you have to see next step is you have to see the mental status of the patient. The moment you know it's alveolar hypoventilation, see the mental status of the patient. The patient mental state can be very altered, drowsy, or mental state can be normal. The patient is in a severely altered state or drowsy and the GCS is low. I mean, I'm talking about the low GCS. That's what I'm talking about. If GCS is low, immediately intubate the patient. Remember, the idea of intubating here typically is not only for ventilation. It is especially for airway protection. Because the GCS is low, you have to definitely protect the airways. So you have to do airway protection. At the same time, we have to ventilate this patient also. Both are needed. So that's why we do intubation here. If it's normal, then see the work of breathing. I told you because there are two causes of type 2 respiratory failure who can't breathe. That is, one is fatigue related and second is your neuromuscular weakness. So work of breathing is increased or if work of breathing is normal. Clear? Work of breathing is normal. So because here whenever the GCS is low means I can tell it's central cause. There's no doubt about that. That's what I'm telling. Now if mental status is normal means itself I can go for it is likely to be a normal or agitated. That's what I mean. It's supposed to be a like diaphragmatic cause. Diaphragmatic weakness. So see the work of breathing. If work of breathing is increased, it is supposed to be a fatigue or exhaustion, likely a fatigue or exhaustion related cause. If it's fatigue or exhaustion, then next step immediately you go for a BPAP. That's called a bilevel positive airway pressure. This is the most important thing because you don't give CPAP typically. Remember, for a type 1 respiratory failure, I told NIV. This NIV can be either CPAP or a BPAP, no doubt about that. You can use anything, not a problem. But whenever you have a fatigue or exhaustion, it's always you have to do a BPAP. That's a very important thing. Very, very important thing. You have to go for a BPAP. There's no doubt about that. You cannot use CPAP. We'll see in the next section on ventilators and how will you do handle all these things. But right now, I'm telling you, BPAP is the preferred thing in patients who are going for exhaustion. Don't use a CPAP here. If it's not responding, or if the patient is getting increasingly drowsy or some other problem is there, go for elective intubation. That's it. So if Burkoff breathing is normal, likely to be a neuromuscular weakness. It's a neuromuscular weakness. Then you have to see whether indication for intubation is there or not. Whenever you see a neuromuscular weakness, you have to see the indication for intubation is there or not. What are the indications for intubation? Number one, is your vital capacity less than 20 ml per kilogram? We saw already in the PFT, the 20, 30, 40 rule. Or if the minimal inspiratory pressure is more than minus 30 centimeters of water, or the maximal expiratory pressure is less than 40 centimeters of water, or if the vital capacity absolute value is less than 1.5 liters. So these are some of the important indications for intubation. If you have this 20, 30, 40 rule, yes, indications for intubation are there, immediately intubate the patient because they are in severe crisis state. If you don't have any indication for intubation but the patient is still having a type 2 respiratory failure, support them with NIV, typically a BPAP. Remember, in diaphragmatic weakness, again I'm telling you have to use BPAP only, you cannot use CPAP because CPAP doesn't support the patient with breathing. They only support the patient to, they only support the airways to open. So here opening of the airways is not a deal at all. Here airways are not collapsed. Here alveolar hyperventilation, it is the breathing is, the amount of breathing is the problem. It's not the airways open only, it's not collapsed. So there is no point in giving a CPAP. BPAP is the only thing that can support the ventilation. So CPAP cannot support the ventilation, and do not give CPAP for a patient who is having a diaphragmatic weakness. You will understand it subsequently in the next section. So this is how you are going to treat a type 1 respiratory failure. This is my personal favorite algorithm. So you can see how you can treat an entire suspected respiratory failure, how you can start with it, how you can go about it in each and every respiratory failure in ICU, how you can manage them, at the same time how you can understand each and every single diseases and how you can assess them also. So this is what I'm going to do, and I hope this particular section on respiratory failure is very easy, and really it's easy, it's not that tough, even though it's a little bit tricky, but it's generally not going to be that tough at all. So just go through it once again if you want, and with this we are completing the respiratory failure section, and the next section will be moving on to the oxygen delivery devices and probably intubation and ventilatory devices.